So, very good evening to all of you. Welcome to the ophthalmology doubt session. So, we will be keep on discussing the important queries and the doubts that you have sent us. Meanwhile, if you have any more query, you can keep on posting in the live chat, and I'll take it as soon as I get it. Right, guys? So, I hope it's the perfect time when I am taking the doubts, because obviously I am getting the academic doubts, but along with the academic doubts you have so much to ask for. What if I am starting now? What if I have done 2 revisions and we are confused whether we should go for further revisions? Will I be able to complete the course now? So there are so many things. I know, with the constant phase of preparation, and we have a stressful time, preparation time is never easy, and it's not easy for anyone. But each one of us and everyone feels that only his or her position is actually struggling. But take my words, actually you all are sailing in the same boat. So sometimes we have one problem, sometimes we have other problem, but life is never easy during this time. But those of you will take this pain and will walk through this, I can assure you that it will lead to beautiful destination. And throughout the journey we are with you. So whatever you have the doubts. Hi Ganesh. So I think you are the only one who is writing to me that I'm feeling lucky, and I'm feeling happy about it that you're feeling lucky, Ganesh. So guys, I want to say now a couple of things. You have time. You have, today is 4th of April. So you have about 25 days of this month, right? You have got 25 days for this month, and about 20 days you are having in the next month also, because the paper is NEET 21st of May. So 45 days is a great time, and I have seen people changing their destiny, changing their times in these 45 days. It all depends upon you. If you think that you will be able to make it, you will be able to make it. If you think that it is impossible now, so obviously it is impossible, because brain will work only that way what you are feeling. So the mind and body are connected. So I will always say that don't lose hope, and 45 days is not a small period. Whatever subjects you have already completed, try to wrap up that fast, so that the next 15 to 20 days you can just revise the high points. And then we have done all the previous year question sessions. So that is again a very big boon. You people were asking that how much percentage can we expect from the previous year questions. So a big chunk, and if I am not exaggerating, at least 30%. 30% of the questions are directly coming from the topics which are covered in the previous year question sessions. So if you take a wider view, it can be even more than this. But to be very honest, it is at least 30%. So whatever time you have, even if you are doing the revision of high yield topics and you are covering the previous year questions of at least last 3 years, you will be coming up with a decent rank, that is assured, right? Hi Parvez, I am good. Hi Aman. Okay, thank you so much. And I like ophtho, but unsure about me being a surgeon. So hi Limo, and thank you for liking the ophtha. One should never be unsure of being a surgeon. Nobody is a born physician or a born surgeon. So we all have to develop that skill actually. And that skill is actually totally, under your hands, so you can always learn it. If you want to, you can always learn it, so that's not a problem. Yeah. Hi Balaji, glad to see you all. And today I am also feeling very happy actually, because all the times we are always talking about the academic doubts, and I always keep on getting the other messages, and I always try to look for the time where I can answer all these questions at a common platform. So today I have got that time, because feeling low, feeling demotivated, a lot of problems related to the low score that you people must be getting. Many of you have messaged me that because score is not improving constantly, so that is also giving a feeling of low energy. See, this always happens in the journey. Whenever you start reading and you start giving GTs, initially they will increase like escalator, but soon they will come to a plateau. So this actually comes to everyone. It's just like the physical mass also. When you start doing the things, the results comes very very fast, but after that also we get a plateau. So this is actually a part of your preparation. Whenever you prepare for anything which is a long term goal, you always get a plateau. Now from that plateau, actually, whether you are going up or whether you are going down, that actually will decide your journey. And that is actually the beauty where you are picking up. So if you have that never to give up attitude, from that plateau you'll go up. But if you will give up at that place, that no, it's not improving, it will improve. Actually, it's a testing time. Everybody has this time. So it is said that it does not matter how low you fall, but it matters how high you go after falling low. So I think this is a testing time, and you should come up with the never to give up attitude. Hi Pankaj, complete rapid revision of I think Pankaj, I keep on doing the revision of ophthalmology, and I am one who is not hesitant to come up live so often, and very often than not we are doing it this. Can we solve clinical MCQs based on gender to some extent in ophthalmology? Balaji, I did not get your question exactly. See, for clinical scenarios, clinical questions, we require the risk factors to actually solve the questions. So you have to look for all the risk factors. You have to look for the age of the patient also, gender of the patient, and other risk factors which are present. But if you want that we can just do the clinical scenario on the basis of the gender, then it is slightly, difficult. Yes. Then we will be discussing some of the important topics also. What are the important topics, high topics that you need to revise in ophthalmology before going to your exam? We will be doing that also. Meanwhile, try to solve this question. We have got a 20-year-old man who is coming with the difficulty in reading the newspaper with the right eye. He is having the difficulty in reading the newspaper with the right eye 3 weeks after sustaining a gunshot injury to the left eye. So this problem is in the right eye, trauma is in the left eye. What is the most likely diagnosis? Now the beauty of these questions are that they are again the most important previous year questions that have been asked again and again. So because they are most important, and I don't want you to be lethargic in these questions. You should be on the toes when these questions are being asked. That is why. Like he is talking about CSR. Yeah, so even if I talk about the CSR so just on the basis that he's a male, I cannot say it is CSR. CSR mein male is also there, then 20 to 50 years is there, stress, smoking, steroids, type A personality. There are so many things which will help in deciding the CSR. So what is this actually? A man is having a trauma in the left eye, and he is showing the difficulty in the reading the newspaper in the right eye. So this is a case of the sympathetic ophthalmitis. Sympathetic ophthalmitis is occurring to which type of trauma? Which type of trauma? So there are so many questions that can be asked, around this. Always, important topics are repeated. You cannot expect a fixed question, but yeah, that important topic is asked. So if I have a question related to sympathetic ophthalmitis, you have to actually revise all of the sympathetic ophthalmitis, right? So what is this actually? Which type of trauma is causing sympathetic ophthalmitis? This is your question number 1. Question number 2 is what type, whether it is non-granulomatous or it is granulomatous. What type of uveitis we have. Number 3, what is the dangerous area of the eye? Dangerous area of the eye. So these are the 3 questions. Can you answer these questions, guys? A person is having a trauma in the left eye. He is having a gunshot injury and he is actually developing difficulty in reading. Difficulty in reading, that means we have a problem in the accommodation. So which muscle is helping in the accommodation? And now extra topics for INI-CT, one session. Alright, we will be doing one session for INI-CT also, promise. That's my promise. I'll do one more session for INI-CT, not a problem. Today we are doing for NEET and one more session we will do for INI-CT. Yes, Aman is right. Dangerous area of the eye is actually the ciliary body. And which type of trauma will cause the sympathetic ophthalmitis? Which type of trauma will cause the sympathetic ophthalmitis? Another question. It's a Kalavati has given the right answer. Yes, this is your penetrating trauma. Penetrating trauma is causing the sympathetic ophthalmitis. Ciliary body is the dangerous area of the eye. And this is your granulomatous inflammation. What is the time period? Usually, what is the time period before the involvement of the 2 eyes? This question again has come up so many times. This was asked in the NEET 2020 also. So, because you people, are always interested in the high topics which we should cover. So, keep on noting down. And if you remember, when I took the previous year question session, that day also I had given 30 important high topics. So, we will be repeating them today again. Yeah. Ciliary body is the dangerous area. Exactly. Ciliary body is a dangerous area. So, if you see, whenever we have involvement of sympathetic ophthalmitis, one is the trauma eye and another is the sympathizing eye. Sympathizing eye, right? So the trauma eye is called as exciting eye. Trauma eye is called as exciting eye and this is called as sympathizing eye. So what is this time period in which the other eye is involved? Another important question, in the time period 2 to 4 weeks is slightly incorrect. Can you tell me the other one? 2 to 4 weeks is slightly incorrect. Yeah, so Suman Das is correct. It is 4 to 8 weeks. It is 4 to 8 weeks. Now, to complete the topic, what is the treatment? See what happens, there is always a confusion whether we should be going conservatively or we should go for the destructive procedures. So see, first thing is we always try to save the trauma eye or the exciting eye. So obviously our first preference is to save this eye. How will I save the eye? Suppose I start the conservative management. So when I start with the conservative management, after starting this management, look for the visual acuity. So this vision will actually tell you what is actually the position of the eye, whether it is spreading or whether it is controlled. So if it is spreading, that means it can involve the other eye also, then it can involve the other eye. If it is controlled, then you can go to the conservative management itself. But if it is becoming less, that means if it is worsening, then this eye will not have vision, plus it can move to the other eye also. Then in that case you have to go for the enucleation. In that case we have to go for enucleation. So first preference is never enucleation. We always want to have the conservative management, but if I am seeing that it's not getting controlled and it is getting increased, then instead of allowing this to go into the other eye, then we can do the enucleation. Now another question is, can I do evisceration here? What is the difference between enucleation and the evisceration? So if I talk about the enucleation, it is the removal of the eyeball. Removal of the eyeball along with a part of optic nerve. Part of the optic nerve. This is the thing that we are doing, right? While what is evisceration? Evisceration means removing the contents of the eyeball. If I am removing the contents of the eyeball with intact sclera, sclera is spared here, that is called as evisceration. So can I do any of them, or I have to do only enucleation? Any answer for this? Can I do evisceration here? Answer is no. We cannot do evisceration because the trauma in this case of sympathetic ophthalmitis, trauma is taking place to the ciliary body. Now because trauma to the ciliary body can cause the sympathetic ophthalmitis, therefore this is also called as the dangerous area of the eye. Therefore it is called as dangerous area of the eye, right? So if I am doing the evisceration, I am removing the uveal tissue from inside, then still some fibers may be left. Then the whole purpose of doing this evisceration is actually disrupted. That is why we are not doing evisceration. We have to actually do enucleation. Sclera can't be spared and uveal tissue may not be completely evacuated here. Can you tell me the name of the instruments also, guys? What is the name of the instruments that we are going to use for enucleation and evisceration? A very simple question, and those of you are actually in the third prof, it's a very important question for you guys, because destructive procedure is something which is first started with. Whenever you are joining the residency in ophthalmology, you are first offered the destructive procedures to do, and only when you are good enough at that, then you are being given the cataract surgery steps and all. So the questions which are being asked at this juncture is mostly from the destructive procedures. So the simple thing is, what instruments you are using for the enucleation and what you are using for the evisceration. Slight difference है, hint है ये, slight सा difference है. Evisceration scissor नहीं बोलेंगे, evisceration and enucleation तो common होगा. What is the name of that instrument, वो सोच के बताओ. Meanwhile हम लोग दूसरा question कर रहे हैं. This is a 54-year-old female, right, presents with the bilateral granulomatous optic nerve head changes. So we are having the optic disc changes and the split fixation in the right eye consistent with the optic disc changes. So this is a 54 years female who is showing you the optic disc changes, and on thorough history taking, she is also having the visual field changes, neural rim tissue also, along with the running intraocular pressure in her teens. So can you see a typical triad is given in this patient? What is the triad of primary open angle glaucoma? Anybody who can write the triad? What are the three things that you are getting in the triad of primary open angle glaucoma? Gonioscopy is documented normal, so that means no angle closure. This is how you have to interpret whenever you are solving the clinical scenarios. She is currently on a very, very important thing, maximum tolerated medical therapy. So you know that the first line of therapy that we are taking in the primary open angle glaucoma is your medical therapy. What is the drug of choice, guys? What is the triad? Number one question. Number two, what is the drug of choice? And she is reporting subjective decrease in the vision. A surgical intervention in the right eye is felt to be the next indicated maneuver. So what is the surgery that we are going to do? What is the surgery that we are going to do? Which of the following treatment modalities would be the best choice for this patient? Now first you people are going to answer, then we will be talking about. Very good. Shubham, drug of choice Timolol. Is it Timolol? पहले था ना. Beta blockers were previously the drug of choice. पहला जो high topic था वो मैंने दिया sympathetic ophthalmitis. Second high topic. I think you people are noting down. Second is your primary open angle glaucoma. Must है. You are getting a question in 2022. ठीक है? Sympathetic ophthalmitis है. Then you have open angle glaucoma. And third is your anti-glaucoma drugs. Anti-glaucoma drugs is again very, very important. So what is the first question? The triad of primary open angle glaucoma. The triad of open angle glaucoma is something like this, right? So we have got the raised intraocular pressure. First is the raised intraocular pressure. Then you have optic disc changes. And the third is the visual field defects. This is the constant triad. ठीक है? Okay. Exactly. Then the second question is, what is the drug of choice? Drug of choice is the prostaglandin analogs. Prostaglandin analogs is the drug of choice. And what is the surgery? What is the surgery of choice that we are going to do in the patients of the primary open angle glaucoma? What is the surgery that we are going to do in the patients of primary open angle glaucoma? So the surgery, basically the question is about the surgery only. The first option is iridoplasty. So what is this iridoplasty? Iridoplasty. Actually, we are not doing iridoplasty. What we are doing is iridotomy. Exactly. I think excellent answers, Limo and Ganesh. Basically, we are doing the trabeculectomy. So, iridoplasty is actually a wrong option. What we do in cases of the primary angle closure glaucoma. Primary angle closure glaucoma, what we do is the laser iridotomy or the surgical PI. Laser iridotomy or the surgical PI. Laser iridotomy is the first thing. And the second is your surgical peripheral iridectomy. So this is the first thing that we are going to do in cases of primary angle closure glaucoma, right? So iridoplasty is not an option. Then your surgical peripheral iridectomy. Now can you tell me what laser we are doing in this case? I am saying that either we do the laser iridotomy or we do the surgical PI. What laser? Because you know lasers is again an important topic. This will be your third topic which is important, and always you are asking the question about this. So can we talk about this? What is the laser? Which laser we are using? And once you tell me the name of the laser, then I will ask you something else also about that laser. So we have got, sympathetic ophthalmitis, primary open angle glaucoma. Then we had anti-glaucoma drugs, and fourth is your lasers in ophthalmology. Yes, you people are awesome. ND-YAG laser. So what we are using is the ND-YAG laser. What is the full form? Hi Akash. When are you going to talk about the exam situations? I'll be talking about this in the midway. Yes, I'll be talking about the stress, but I think it will be better to address a particular thing. If you people are facing any particular thing, I won't be mentioning your name, but I will be addressing those problems. So please post your doubts related to this also, and I'll be talking about them, because everyone is having a different problem. Life is different for everyone, and looking at a particular problem is also a different perspective for everyone. So if you tell me your problem, then it will be better for me to talk about. So ND-YAG, what is the full form of ND-YAG and what is the wavelength of ND-YAG? Oh, Ganesh, excellent. We have got neodymium, yttrium, aluminium, garnet. Neodymium, yttrium, aluminium, garnet is the name of the full name of this laser. What is the wavelength of this laser, guys? And mechanism of action bhi bata do, because these are the things which are most frequently asked. Neodymium, yttrium, aluminium, garnet, and what is the wavelength? Wavelength ये ठीक नहीं है, थोड़ा सा और सोचो. What is the wavelength? Wavelength is actually 1064. Now what is the unit? Unit भी बताओ. 1064 what? We have got 1064 nanometer. Yes. So lasers are again important. The mechanism of action. Mechanism of action, because here we are doing the cutting. So whenever I am doing the cutting in the iris, it is actually the photo disruption. It is the photo disruption. The mechanism of action of this laser is the photo disruption. Yeah, Limo, actually क्या होता है कि whenever you are learning any thing for the first time, then you get to feel that it's unreal. But once you are familiar with the name so many times ना, अगर आप देखोगे तो साउथ इंडिया में तो इससे ज़्यादा लंबे names होते हैं, and everyone is remembering the relative's name and his or her name, तो it's not that unreal, याद रह सकता है. Okay. NM is the nanometers. And yes, the mechanism of action is the photo disruption. It is the photo disruption. Okay, now the next important one. This is something related to the neuro-ophtha, which is an important one. Neuro-ophthalmology say questions are always bound to come, So we have a 6-year boy. 6-year-old boy coming, brought to the physician by the father for the annual maintenance examination, right? Father notes that he has several pigmented areas on the skin and the fleshy bumps. He is also having blurred vision. There is no history of the serious medical illness. He lives at home with both the parents and up to date, all immunization done. ठीक है? Now father may be similar skin findings हैं. So what should be the genetic inheritance? ये पैथो पार्ट है, बताओ. पैथो पार्ट है. If a boy is having the pigmented lesions and the father is also having the similar skin findings, Mother is having epilepsy and glaucoma. Vitals are normal. Visual acuity. Look at the visual acuity. 20/50 in the left eye, 20/20 in the right eye. And ye highest hint hai. We have got pigmented iris nodules. So we have got pigmented lesions on the skin. We have got pigmented iris nodules. Father and the son both are having the things. Mother is having epilepsy and glaucoma. Examination shows 8 brownish macules, and we have got pedunculated lesions on back, chest and abdomen. Which of the following is the most appropriate next step in the management? Now, I can assure you that telling the next step in the management is not a problem if you are able to diagnose what it is actually. Oh my God. इतनी अच्छी मैंने ऑफ्था पढ़ाई है that everybody is able to give the answers, yeah? So, how it is neurofibromatosis? Very good. So, this is actually awesome diagnosis by my students. It is a case of neurofibromatosis. Which neurofibromatosis? 1 or 2? This is neurofibromatosis 1, which is autosomal dominant. So what are the features that I'm going to get in neurofibromatosis? We have got the cafe olate spots. We have got the cafe olate spots that are there. Then we also have the axillary freckling. We have got the axillary freckling. Cafe olate spots are there. We have got axillary freckling. That is also there. Then we have got the third thing, that is your Lish nodules. Now, who will tell me quickly what are these Lish nodules? Cafe olate spots, sabko pata hai. Neurofibromas will be found. We have axillary freckling also. So, one is there, cafe olate spots. Limo, Lish nodules. What are Lish nodules, Limo? Yes. You can call it by the other name also, Ganesh. So, what are these Lish nodules actually? You have to tell me this. And what is the complication which is associated with it? Complication. What is that complication which is actually associated? Hi Ujjwal. Ujjwal, Koipe nodules and Bosaka nodules are of course found on the iris beta, but they are not Lish nodules, right? So it's good that you have come up here so that I can correct you and don't do this mistake in the examination, right? Okay, yes, Lish nodules, please correct. It is the iris hematomas. These are the iris hematomas. Yellow, yes, yellow you can say or brownish hote hain. Basically they are the brown colored iris hematomas that you are getting here. So what is the most appropriate next step that you are going to do here? What is the most appropriate next step? Now, most appropriate next step will depend upon what complication I can have. Simple hai. So can you tell me? Nothing to feel sorry. It's good that you are doing mistake here. I am happy that I am able to correct it. Fortunate enough, hai na? Not a problem. Ujjwal, you should not be sorry for this. Okay. So, what is the complication? What is the most commonly expected complication that you can have in the patients of neurofibromatosis 1, jiske liye we have to do a test? Wo bata do. Oh my God, yes. Again, you know, Ganesh and Limo aise chal rahe hain, first second, right? Yes, so we can have the optic gliomas. We can have the optic gliomas. How many % of people can have optic gliomas? Ek to, you tell me the percentage. Number 2, what is the appearance that you are going to get on the radiography? Lish nodules are not pink colored, Ganesh. They are iris hematomas, but they are brown colored. ठीक है? Appearance on the radiography. What kind of appearance you are going to get in cases of optic gliomas? Krish nodule. Auto correct से Krish nodule हो गया. Okay. So appearance बताओ and percentage बताओ. It is about 15 to 20%. 15 to 20% patients में risk है optic nerve gliomas का. Exactly. So because 15 to 20% में है, तो you cannot rule out. 15 to 20% is a large area. Now what type of appearance you are going to get here? The appearance that I am going to get is a fusiform appearance. So what is the investigation? Now you can easily tell what is the investigation, and can you tell me where do you get the tram track appearance? Tram track appearance. Which tumors will show you the tram track appearance? That also. So what is that investigation that you would like to do in cases of the optic nerve? What should be the answer here, guys? CT scan of the brain, MRI of the brain, gonioscopy or EEG. What should be done? Tram track appearance. Where do you get the tram track appearance? Again, a very very important question, है ना? ऑफ्था का है भी और ऑफ्था से रिलेटेड भी है, इंटीग्रेटेड है ना रेडियोलॉजी से. स्टर्च वीबर सिंड्रोम में कहाँ ट्रैम ट्रैक अपीयरेंस मिलेगा? This tram track appearance you are getting in cases of the optic nerve meningiomas. So basically you can get an integrated question because here you are getting a skin involvement also, eye involvement also, radiographic involvement भी है, treatment भी पूछ सकते हैं, prognosis भी पूछ सकते हैं, and what is the investigation that you are going to do वो किसी ने नहीं बताया. What is the most important investigation that you are going to do here? वो भी बता दो. meningiomas is correct, वो मैंने देख लिया है, very good है. So for the optic nerve, what is the best investigation? That is your MRI. So MRI will be your best answer here because for the optic nerve we do the MRI. ठीक है? How many people are facing the stress and anxiety so that we can talk about it? Exactly. A child with the whitish pupillary reflex, ये क्वेश्चन भी एक ऐसे टॉपिक से है which is bound to come in 2022. बहुत ही important है. You can take this as a next high yield topic. 5 to 6 topics हम लोग already कर चुके हैं. This is your next one. A child with the whitish pupillary reflex, he has undergone the enucleation. अच्छा, I had to tell you the instrument name also ना. For the enucleation के लिए we have to use the enucleation spoon with the optic nerve guide. This is used for the enucleation. ठीक है? And then next is your evisceration. Then next is the evisceration. Evisceration के लिए we use the evisceration scope. इसके लिए we use the evisceration scope. Enucleation के लिए we use the enucleation spoon with the optic nerve guide. Yes, and for evisceration we use the evisceration scoop. क्योंकि क्या होता है कि in cases of evisceration you are scooping out the contents from inside. You are not removing the optic nerve. What are the things that you are preserving in the evisceration? क्या क्या preserve करोगे? We are preserving the sclera. So when you are preserving the sclera, all the structures which are concerned, which are associated with sclera will be preserved. है ना? Extraocular muscles are inserted over sclera. Optic nerve is coming out. So optic nerve is also spared. Extraocular muscles भी spared है. Sclera भी spared है. While in cases of enucleation, we have to remove the optic nerve. So we have to actually cut the optic nerve. So I require an optic nerve guide. Can you understand the difference between the two? ठीक है? Difference between enucleation and evisceration. What is the difference? What is the difference between the enucleation and the evisceration? So now coming back to this question, we have a child with a whitish pupillary reflex and undergone enucleation. We have done the enucleation. What are the indications of enucleation? If you know what are the indications of the enucleation, you can easily answer this question, and you are also getting the Flexner Winter Steiner rosette. I think this is the biggest clue of this question. Flexner Winter Steiner rosette. What is the diagnosis, guys? Come on, we have got three things. We are having the leukocoria. Leukocoria भी है यहाँ पर. उसके अलावा enucleation we are doing, and third thing is the Flexner Winter Steiner rosette. So what is the diagnosis? Diagnosis, I am telling you, is very very important here, and it's a must topic for your NEET and the very important high yield topic for your INI-CT as well as NEET. क्या आंसर है इसका? Exactly. So answer is the retinoblastoma. This is the next important topic. Please note down. You have to read everything about retinoblastoma. Everything मतलब everything. Starting जो है, you have to do it from the tumors of the eye. Sclera is left. Yes, sclera is spared in cases of evisceration. So if I talk about the tumors, in the eye, then they can be divided into two types. We have got the primary tumors, and then we have got the secondary tumors. Primary tumors and the secondary tumors. Primary tumors are not most common in eye. First of all, it is the secondary tumors or the metastasis which is actually common in the eye. Primary tumors are not common in eye. It is the secondary tumors or the metastatic tumors which are actually common in eye. Primary tumors, if they are asking, then they can be divided into two groups. Okay, this is a very important flow chart. That is why I am making you write. So we have got the intraorbital tumors, and then we also have the intraocular and intraocular. ठीक है? Now whether it is intraorbital or whether it is intraocular, you can again divide it on the basis of the age. Adults, children, adults and children. So what is the most common primary intraorbital tumor in the adults? In the adults, the most common is the cavernous hemangioma. While in cases of children, it is the rhabdomyosarcoma. Then the most common primary intraocular tumor. Intraocular tumor in the adults, it is the malignant melanoma. And in cases of the children, it is the retinoblastoma. So the first question that could be asked is about the metastasis. The most common tumor is the metastatic tumors in the eye. Then the next they can ask you about the primary, intraorbital and intraocular. ठीक है? So if they are asking, you have to see whether they are asking about intraorbital or intraocular. Intraorbital in adults is this one. Then intraorbital in children is rhabdomyosarcoma. Intraocular in adults is the malignant melanoma of the choroid, and intraocular in children is the retinoblastoma. Now if you see in adults, it is the benign tumor that is more common. Cavernous hemangioma is a benign tumor. So in cases of adults, it's a benign tumor that is more common. But if they ask you about the malignant tumor in cases of adults, then your answer will be non-Hodgkin lymphoma. While rhabdomyosarcoma is a malignant tumor. It's a malignant tumor. So if they are asking you about the benign tumor in children, then your answer will be the dermoid cyst. So about 7 MCQs are actually solved from this flowchart. Very, very important. 7 MCQs are solved from this flowchart. Yes, so I hope you got this chart, and retinoblastoma is a very, very important topic. Please keep on noting down the important topics. Another very important topic. Very, 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 very to the infinity. ठीक है? So this is a 1 month baby. Baby is coming. Instant answers चाहिए इसके लिए मुझे instant answers. This baby is coming with watering and megalocornea. What is the diagnosis? Come on. This baby is coming with the watering. Hi Shri Lakshmi, for molluscum contagiosum you have to do the excision. For molluscum contagiosum we get umbilicated nodules and there we do the excision of that lesion. Let me talk about that. See, Shri Lakshmi, I have got a similar question for you. This is a 45-year-old patient coming with photophobia, watery discharge, tearing, and image you can see which treatment is the most appropriate. Can you see? This is actually a case of molluscum contagiosum. You can see a umbilicated nodule here. This is the umbilicated nodule. This is of molluscum contagiosum. So basically, we can do cautery also, and if that is not working, then we can go for the excision also. So cautery and excision are the main treatment that we are doing for the molluscum contagiosum. Hi, good evening Satvik. Satvik, you have joined so late and every time you are the one who is asking the questions. Today you have not asked any question. So ask me the questions. So yes, I think everybody has given me the right answer. सारे जितने दिख रहे A is the right answer. इसको मैं कलर भी ब्लू से करूंगी. फेवरेट है मेरा, है ना? जो लोग मुझसे पढ़ते हैं they know. So it is actually a blue baby boy. It's a blue baby boy. Or people know the history of story of Bablu na. This question was asked by the name of Bablu in AIMS actually. B for blue baby boy, Bablu. B for bilateral, B for boys. And then B for Ophthalmos. It is a case of the Ophthalmos. So what are the important complaints that are going to be shown in this case? Ophthalmos mein. What are the important things? So if I am having this Ophthalmos, always remember this baby will come with the BPL card. This baby will come with BPL card. So this B is again blepharospasm. B for blepharospasm is there. Then we have P for photophobia. And we have L for lacrimation. So these are the usual complaints with which the baby is coming. Blepharospasm, photophobia and the lacrimation. Oh my God, are you alright Satvik? Casualty में ड्यूटी कर रहे हो ना? पेशेंट तो नहीं हो? Good. Please carry on with your duty. बहुत अच्छे से करो and keep on doing good work. ठीक है? So we have blepharospasm, photophobia and lacrimation. जिसमें से photophobia, is the earliest complaint and lacrimation is the most common one. These are the first thing. Then secondly, you can also have the corneal edema. Corneal edema is called as the frosted glass appearance. This is called as the frosted glass appearance. This frosted glass appearance is not only earliest but also specific. It is actually earliest specific. Then we have got the number 3. Number 3 we have the megalocornea, which is also given in the question. Megalocornea more than 13 mm is actually diagnostic. Megalocornea more than 13 mm is diagnostic. And what is the name of the stria? Who will tell me the name of the stria that you get? Then number 5, it is also having the blue sclera. B for blue sclera also. See, we are having this blue sclera. This baby is also showing the blue sclera. And then we have number 6, B for backward subluxation of the lens. We have B for backward subluxation of the lens. These are very, very important things. B for blue sclera, B for backward subluxation of the lens, B for blepharospasm, B for puphthalmos, B for blue baby boy, B for bilateral, B for boy. So again, very, very important. Please note all these things. They are quite important. Exactly. So these are actually your Harp stria. Harp's stria. Harp stria are the horizontal striations. These are the horizontal striations that you are getting due to the rupture of the Descemet's membrane. So again, a very, very important question and a very, very important topic, guys. Okay. Important question on the anti-glaucoma drugs. Important question on the anti-glaucoma drugs. A patient of primary open-angle glaucoma is a known case of bronchial asthma. So drug to be used. They are not saying which drug should not be used. They are saying which drug to be used. A patient of primary open-angle glaucoma is a known case of bronchial asthma. So which drug to be used? Corneal length, either in children or infants or in adults, we are using the same vernier calipers. With the help of vernier calipers, if you want to measure it exactly, then we are doing it with the help of vernier calipers. Okay. Yes, so it is the retinoblastoma. See, in cases of the bronchial asthma, we cannot use non-selective beta blockers. So timolol is strongly avoided. We can give the selective beta blockers. But out of these drugs, because they have given the prostaglandin analogs, so letinoprost will be the best drug that you can give. Letinoprost is the best drug amongst these drugs. Okay, coming to another important question. This is again very, very important. This you got recently, and now there is a trend of asking the question along with the lesion also. They are not just asking the fundus image, they are also asking the lesion. And I think this is again very, very important, the fundus images. Another high topic is the fundus images, and I think fundus images may be diabetic retinopathy and the hypertension retinopathy are very, very important. तो हाई यील्ड है एंड हाई यील्ड टॉपिक्स के साथ साथ आई एम डिस्कसिंग द क्वेश्चन ऑल्सो, सो दैट विल अगेन हेल्प यू. Elderly female is coming with the gradual painless diminution of vision. What is this? Can you see the size? Can you see the color? What is this? These are the hard exudates. Exactly. These are the hard exudates. And where do you get the hard exudates? What is the difference between hard exudates and the soft exudates? Can you tell me the difference between the hard exudates and the soft one? I have tried to show you the difference also. See guys, this is again very, very important. At a glance, if you see, there is lot of difference between the hard exudates and a soft exudates. These are actually your soft exudates. The soft exudates are actually, large, fluffy and the laudacious. Large, fluffy and laudacious are your soft exudates, while these are your hard exudates, smaller, yellowish lipids, waxy deposits. So there is a difference between the hard exudates and a soft exudate. Soft exudates are larger. They are actually the neuronal deposits. These are the neuronal deposits that are found, while the smaller, yellowish, wax colored, because they are actually the lipid deposits, they are actually the hard exudates. I hope you people are getting this. This is very, very important. The difference between the hard exudates. Very good. Exactly, Shri Lakshmi. I am happy that you remember here. Dirty fundus. D for diabetes and D for dirty fundus. वो याद है. Very good है. Lipids. Hard exudates are the lipids. So they are yellowish. Soft is your neuronal deposits. How to distinguish between the flame shaped hemorrhages and what? Distinguish मतलब two चीजें होती है ना. Flame shaped hemorrhages are your flame shaped. They are found in the hypertension retinopathy. See this. Can you see? These are flame shaped hemorrhages. So flame shaped hemorrhages are actually the superficial hemorrhages which are found in the hypertension retinopathy, because you know they are spreading only in the superficial layers. That is why they are called as the flame shape, because they are taking the shape of the flame. While in cases of the diabetic retinopathy, they are deeper. So when they are actually deeper, they are going in the circular fashion. So if you have the smaller, if you have got the smaller circles, then these are your dots. If you have got even larger circles, then they are blots, like this. So these are your dots, and these larger ones are called as blots. These are called as the dots and blots hemorrhages. While in cases of hypertension retinopathy, they are superficial, taking the shape of the flame. In cases of diabetes, they are deeper. So they are going in the deeper layers. There they are taking the shape of circle. So that is why they are called a dot and blot. ठीक है? I hope you got this. तो अभी अगर वापस चलोगे, so these are hard exudates that you know. So they are not the flame shaped hemorrhages. They are not the soft exudates. And what do you get in cases of CRVO, guys? What do you get in CRVO? Answer to we already know is the hard exudates in the diabetic retinopathy. Anybody who can tell me what is CRVO? What is the appearance that you are going to get in CRVO? What is what is this? A very, very important fundus picture. It's good that you asked me this. This is a very, very important thing. Yes, Costa, you are correct. Splashed tomato appearance. It looks as if somebody has squeezed the tomato inside the fundus. So many hemorrhages you are getting. This is the typical appearance that you are getting in cases of CRVO. So obviously they were not hemorrhages. They were not flame shaped hemorrhages. It is not the splashed tomato appearance in the CRVO. So it is the hard exudates in the diabetic retinopathy. And what you are going to get in CRAO? CARAO is again very, very important, and I think no examination is complete without CRAO. Do you remember this? Do you remember this? Cherry red spot due to the occlusion of the central retinal artery, because you know choroid is hidden, and the only area through which the choroid remains visible is through the fovea centralis. It is the only area through which the choroid remains visible, because you know rest of the areas are supplied by the central retinal artery, but the foveal blood supply is by the choriocapillaries. So only area which is normal through which the choroid is still shining is the fovea centralis, and that area is called as cherry red spot. तो DD भी बात कर लेते हैं. DD is also important. What is the DD of cherry red spot? The DD of, oh my god, the DD of the cherry red spot. So we cannot, forget this cherry red spot, which is always important. Cherry red spot की DD भी बता दो. We have cherry trees never grows tall in mud and sand. Cherry trees never grows tall in mud and sand. So what is the DD, guys? Yes, Krish is telling me correct. So here you have got the CRAO. Then we have the Tay-Sachs disease. This is the Niemann-Pick disease. Then we have the gangliosidosis. Then T for trauma. T for trauma. Then we have got the T for trauma, and then we have got the metachromatic leukodystrophy. Metachromatic leukodystrophy is there. And finally, we have the send-off disease. Finally, we have the send-off disease. This is the whole DT of the cherry red spot. Very, very important. The DT of the cherry red spot. So, right, guys. So, I think high-yield topics are covered. We discussed some important doubts as well as clinical scenarios. Now, something about the stress anxiety that we were talking in the beginning. See, all of you must be in your different phases of preparation. So I do not know what one line can suit you all. But the thing is that you have to keep on working. The show must go on. So at whatever point of preparation you are, don't actually stop thinking that ab nahi ho paega, we will not be able to do it. Yeah, now it's not possible. Now it is beyond my reach. No point is beyond your reach. It's only in the minds. And once you start believing that you can do it, you will actually do it. So, and if I tell you feasibility, 45 days is a big deal. That is not a less time. So even if you have not done something, even if you have not, gone through the things, you have the time. Leave the other things and go through those topics first, okay? But also you have to do the smart study, okay? If those topics have not been asked in the last, 5 years, then perhaps you can leave them now, okay? Because basically, entrance examination is more of smart study. So you have to basically, judge and give the priority to those topics which have been asked frequently, and you will have to prioritize your time. You have to do more of questions now. So always divide your time, every day of your time, into hours, okay? Don't waste your time thinking ki aaj nahi hoga, kal nahi hoga. See, even if you have wasted 1 hour, you have 23 hours. Even if you have wasted 2 hours, you have 22 hours. So after taking out the time for sleeping 6 hours, and maybe you have wasted 2 hours, and maybe you are not feeling like studying 2 hours, then also you have 14 hours. So make sure that you are reading more than 10 hours daily. Means 12 to 14 hours you have to read daily, okay? 1 or 2 hours obviously will go here and there. Every day will not be same. But if you will keep on pushing yourself, you have to actually feel that this is the last time that I am going through the phase of struggle, and then the winner is lying inside you. So if you look at other side of that 2 months, you are standing at a winner's position with your dream college, dream seat, and whatever. So don't just finish off prematurely. Don't let your energies lose just before the final time. You are very, very close to the finish of line. Try one more time. Try, and keep your energies high. Self-doubt is the biggest problem at this moment. But believe me, everybody is having that. So you have to believe in yourself. No matter, I say so many times that you can do it. But until and unless you feel it that you can do it, that won't work. So, it is always said that the quotes work only if you work. So, my motivational quotes that I am, posting, they work for you because you are actually working according to them. So you have to keep on working, no matter how much you are able to do it. Take it every day as a challenge, that today I'll give my best. Then you have to see what better I can do the next day. Okay, and also take enough time for the rest, because a cool mind only can do the maximum work. So don't take stress. See whatever you can do maximum, try your best, give your best attempt, and also divide your time, a good amount of time to the MCQs also. MCQ practice is one thing that cannot be ignored at this time. Give the frequently GTs also, at least once in a week. Keep one day for assessing that GT also. If you are not able to review the GT, there is no point of giving the GTs. Because if you are not able to go through your mistakes, how will you actually work on your mistakes? So I think it's a high time that you work on your mistakes. You have to increase the number of positives, and plus you also have to decrease the number of negatives. So the number of negatives can be actually decreased only by practicing the test. Number of positives you can improve by studying more and more and more. Okay, so you have to work side by side, do theory, try to improve your attempt by doing more and more topics, more and more subjects, and meanwhile also start doing the tests, so that you are also decreasing your negatives. And believe me, if both the things will go hand in hand, you are increasing the number of positives, you are decreasing the number of negatives also, your GD score will definitely improve, and then are ahead. Even if it is not improving, that's not a problem, because GT score is not going to give you your college. So it is your continuous practice. You are daily learning from something. It is always said that whenever you are getting failure, that is actually not a failure, because next time you have that experience. You are not starting from a scratch, you are starting from a lesson. So basically, even if you are not getting marks in that, at least you are learning, and you have been over on so many mistakes. So keep on working hard, and I can assure you that life will become very, very smooth for you. Got seat in mop-up, but then it got cancelled. Very demotivated. I'm a post-intern. Now I can compete with those who are studying seriously. Definitely, I think they have to worry that how can they compete you actually, because you were already getting a seat. So I think you have already done your things. Just, you require one more revision and you are good to go. So please keep on working hard. Ganesh, which phase of preparation you are, I do not know. Are you an intern or a post-intern? Because 9 hours sleep is little too much from my side. You are studying 6 hours and you are sleeping 9 hours. I think it should be other way around. So a little change has to be done in that perspective. Then I'll be coming with a 45-day strategy also. So those of you are in the times of revision, I'll be telling you one plan for those people and one plan for those people who are trying to start from the newer end here. Can I do it even if you... Yes, exactly. 45 days are enough, good to go. So even if you start today, you can do it. But the thing is that you have to quantify that what things you are doing and how much you are doing. You have to basically concentrate on the high yield things. And you don't have to cover A to Z. Just keep on revising the high yield, and also focus on your previous year questions. Do a lot of practice of the MCQs and you can definitely do it. Hi Harshit. So yes, as I was saying, you are getting a constant one, and you are not improving from 2 weeks is not a problem, but make sure that you are not doing the same mistakes. Do mistakes again and again, not a problem, but don't do same mistake again and again. Learn from each of your mistake. Okay, I think you must not be assessing and reviewing your GTs. Please assess and review your GTs and see which subjects or which topics you are doing maximum mistakes. You should first concentrate on those subjects and those topics, and your score will definitely improve. So Ganesh, I think you should reverse your sleep wake cycle, and that will definitely help you. Um, Hi Shailesh. I need to example. Yeah. So guys, here we are talking about the NEET PG actually, not the UG one. Anyways, good luck to you also. Uh, yeah, so at eGurukul, Robin, we are having so many plans. What is best suited for you actually depends upon your status. Are you a third prof student or a final prof, intern, post intern? And if you will be telling me that, then actually I'll be able to help you which course will be best suited to you. So guys, I think we have come up to the end of the session. It was very, very nice talking to you all, and I hope I have been able to give the answers to all the questions. If still are left, then we are all open to you on all the social media platforms. You can keep posting me your doubts, and I will be more than happy to solve it. Keep studying and keep rocking. Thank you and goodbye.